Thank you, Petrus. I'm delighted to be here. Appreciate the invitation and the work of you and the organizing committee in putting together a great conference. I wanted to just say at the outset that this keynote will be a little different in that it's mostly clinical and descriptive about elements of treatment. So as Petrus mentioned, at Duke, we've been fortunate to be involved in a number of adolescent treatment studies for major depression, anxiety, OCD, suicidal behavior, and so forth. And so we've worked with colleagues across the country developing treatment protocols and struggling with the issue of how to disseminate effective treatment. And I'll be talking from that perspective. Is this working? Oh, there we go. Okay. So I'm going to take a perspective from cognitive behavior therapy, which, as you probably know, has been shown to be effective for many disorders in young people, including anxiety disorders, obsessive-compulsive disorder, depression, substance use disorders, and post-traumatic stress disorder. And some of you may have taken the workshop yesterday with Dr. Rosenstein and Dr. Kaminer, which focused mainly on CBT for anxiety disorders, OCD, and post-traumatic stress. So I hope you'll see some tie-in between what I say about depression and substance abuse and what they conveyed to you about the treatment of those disorders. It's so effective that it is widely disseminated for depressed and anxious adults in the British National Health Service. And so I thought, as I was preparing for this talk, I thought, well, what is it that we should try to focus on if we disseminate the results of the studies that we've done to date for other settings? I'm not going to talk much about the outcome research. I'll just refer you to two summary articles. These are both in the Journal of Clinical Child and Adolescent Psychology, which publishes updates about every 8 to 10 years on the evidence base for different treatments for different disorders. And in summary, the well-established psychotherapies, that is, psychotherapies that have been shown to be effective in more than one well-designed study in more than one setting, are fairly limited. There are only two for adolescent depression, CBT and interpersonal psychotherapy, and there are 4 for substance use disorders, CBT and 3 different kinds of family therapies. So CBT has the advantage of being a well-established treatment for both of these disorders, and those are the two I'm going to be talking about today. So in thinking about dissemination, it seemed to me that to disseminate CBT to providers in the United States and in other countries, you really need to have an understanding of the basic CBT model, and then you have to understand the strategies that are used in the treatment of different disorders. So I'm going to talk briefly about a general model, and then I'm going to apply it to depression and substance use disorders. And for depression, most of the studies have involved young people with major depression. And for substance use disorders, they're mainly involving young people with alcohol or marijuana addiction or abuse, okay? So this may not be as directly relevant to harder drug abuse like cocaine or heroin or opiates. But to start with the general model, if you want to think in terms of CBT as a intervention, it helps to think first of all as thinking of clinical problems as involving behavior, thoughts, and emotions. So this is the triangle that Peter Lewinson wrote about 20 or 30 years ago when he was starting his treatment studies for adult depression. And then you want to do a functional analysis of the problem to see how it is affecting the thoughts, the emotions, and the behaviors of the person, and what are the situational factors that are maintaining it. Once you do this functional analysis, then you can use the strategies, which are various kinds of change strategies, to target the factors. So this general model can be applied to adolescent depression, substance abuse, and anxiety disorders, or PTSD. So here's the triangle. This is something that most adolescents easily get a handle on. You have some event that happens, and it affects the individual's behavior, thinking, and emotions. For example, if I'm hanging around with a bunch of friends who are using substances and they urge me to use substances, that's a social pressure, which we know is a very high predictor of substance abuse in adolescence, hanging around with peers. That may affect my thoughts, such as, well, I better do this or otherwise they won't like me. My feelings of wanting to do it to please, and my behavior of using. Okay? Now, to do the functional analysis then, you ask yourself, what is the function of this behavior? So the behavior, I'm going to start with an example from substance abuse and then go to depression and then get back to substance abuse. Let's say using marijuana or using alcohol, the function of that target problem, does it lead to pleasure, reward, attention, avoidance of distress, or relief? That's when you want to ask yourself when you're doing a functional analysis. What is the function of the behavior? What situations, thoughts, and emotions are associated with it or lead up to it? And then what are the consequences? Okay, so let's take a look at depression now. So in applying the CBT model to depression, the situation is usually some kind of perceived loss or failure. So you may have the loss of a relationship. You may have breaking up with a boyfriend or girlfriend. You may have an academic failure. You may have lots of stress in the family. That's the situation that's leading to the reaction. The depressive reaction is to feel low mood, bored, depressed, or irritable. Usually that's associated with thoughts of self-criticism or criticism of others, or hopeless thoughts about the future. The typical depressive behavior is social withdrawal, which has the consequence, a short-term consequence of relief and avoidance of pain, or even avoidance of sadness. There are interesting theories that say depression is actually the avoidance of normal sadness. The long-term consequence, however, of withdrawal is that you lose enjoyment, you lose social reinforcement of being with other people, and you have a maintenance or recurrence of the negative mood. So in treating a young person with depression, or really a person of any age, you would ask them to monitor the depression by filling out something like this. It could be done on paper, or it could just be done in an interview with them. What was going on around me that led to this change in emotion? What was I telling myself? How did I feel? And what was I doing? Okay, so there you have the triangle laid out, ready for a functional analysis. So, for example, a teenage boy fails a math test. If they have a tendency toward depression, they may interpret that to mean that I am stupid. They may then feel sad, discouraged, or hopeless. And if they feel hopeless, then they're going to shut down and stop the work in school, which leads to worse outcomes, okay? So that's a mini example. That certainly wouldn't be, that's not a major depression, but that's a kind of a depressive reaction. So to do CBT for depression, you target the withdrawn behavior and the negative thinking. So essentially, CBT for depression is a way of trying to change behavior or change thinking in order to change emotion, okay? You look at the withdrawal as preventing reward, and then CBT involves getting the patient to change their behavior and to challenge their negative thoughts. Now, I'm not going to say much about this, but I wanted to put the slide in there because I don't want to convey, because I'm talking about strategies, I don't want to convey the idea that those are the only things that matter. In fact, these things might matter more. The therapeutic relationship, the working relationship with the parents, having shared treatment goals. We know from John Weiss's studies on various treatments for depression that that's an important element of successful treatment. Educating the parent and the adolescent about depression and about CBT, and using a consistent session structure so that you review the previous week, you set an agenda and work on the agenda with the adolescent. Then you work on a skill or strategy and develop some kind of a homework assignment. Now, whether adolescents ever do the homework assignment, that's an interesting question. When we did the treatment for adolescents with depression study, we had big debates about whether to even ask them to do homework. We decided to ask them, and it turned out about 75% of the time the therapist did work with them to develop a homework, and about 75% of that time, something got done, something. Not the whole thing, something. Okay, so now I want to talk about strategies that have been found to be successful in CBT for depression. First one is called behavioral activation. And in fact, there is a development now in the United States to use behavioral activation as the treatment for depression. So if you have to disseminate only one strategy, this might be a good one to do because it's been shown that this can be an effective treatment in itself. What you're trying to do here is counter the withdrawal of the adolescent by getting them to re-engage in pleasant, non-harmful activities, including some that are social. One way to do this is by what Lewinson and Greg Clark and Paul Rohde do is increasing pleasant activities. So you generate a list of activities with the adolescent that they like or might like or used to like, and then you obtain a baseline to see how often they've engaged in these activities in the past week, which usually, if they're really quite depressed, is pretty low. Then you select a few of them to increase in the coming week, and you make plans for how they're going to do that, and you work through challenges to doing that. You ask them to monitor the connection between doing these things and the way they feel, and to give themselves a reward if they complete the activity. The problems that you'll run into in doing this, of course, will be you have to do this when you don't feel like doing it. So in a way, this is sort of like exposure for anxiety disorders, where you have to let yourself be exposed to the thing that makes you anxious. Here you have to do things even when you don't feel like doing them. And you have to deal with the thoughts that may get in the way or unrealistic expectations that may get in the way. But that's the first strategy that I wanted to propose to you as something that you could use in disseminating CBT for this problem. Second one is problem solving. Now, if you've done CBT for anything, you've probably done problem solving because problem solving seems to be in every CBT manual for everything. So probably this is a good one to use. This counters both passive behavior and pessimistic thinking, okay? And it's useful, it's only useful when the adolescent can effect change. So you cannot use this to help with conflict between the parents. This isn't going to do anything about that because the adolescent doesn't have any control over that. So it has to be something that they can have an effect on. But the third one that I'll talk about could be used in that circumstance. So for problem solving, there are lots of different acronyms that people use. They all pretty much get down to the same thing. We use this ribeye acronym because it's completely ridiculous, and that makes it easier to remember, okay? So it means first relax, because you can't solve problems when you're upset or tense. Then take time to identify the problem and try to identify it as specifically as you can and identify what part of it is yours as opposed to your friends or your parents or the teachers. Then the brainstorming part, which is to help people think about as many possible solutions as they can without evaluating them. So in doing this, it helps to encourage the adolescents to come up with all kinds of possible solutions, even ones that they're later going to rule out as not being feasible. Okay? You separate that step from the next step, which then to evaluate the possible solutions in terms of what are the positive consequences if I do that, what are the negative consequences if I do that. And then choose one. So we had to think of something for why. So I said yes, yes to one. That means choose one. And then encourage yourself because you did it and we can see how it goes. So this is the acronym that we use in our studies. Other people use other ones. But the principle is the same thing. This is a method to increase behavioral and cognitive flexibility. The possible barriers that you will run into with kids, some kids have a negative problem orientation. That is, they don't feel like they're competent to deal with the problem. And so you'll have to work on the cognition there, okay? Some of them have an impulsive style, which means they go for the first solution that comes to mind, and you have to then work with them to learn to slow down and delay. Others will have an avoidance style. They just don't want to deal with the problem. And there you're in a similar situation as for anxiety disorders. So you have to help them get used to dealing with the problem and becoming less anxious about it. And a very common barrier that happens in therapy is the therapist starts to do problem solving with the kid, and the kid brings up the biggest possible problem in their life to start with. It's like, when you do school consulting and they tell you they're going to send you a typical kid to talk to, and they send you the most difficult kid in the school the first time you're there, right? Everybody's been through that, right? So those are the first two strategies. The third one is the one that is most well known from the work of Tim Beck, which is cognitive restructuring. And this has to do with becoming more flexible in your thinking. Realizing there's more than one way to look at things, and understanding that the way that we look at things affects the way we feel. So I like to ask kids to think about being in a car accident in which no one was hurt, and tell me at least two feelings you could have in that circumstance. Or you could feel relief that no one was hurt, or you could feel anger that somebody hit your car. It depends on what you focus on, how your emotional reaction goes. And then learning to talk back to depressive thoughts. So here is an example of what the cognitive therapists do. They map the relationship between events or triggers, thoughts, and emotions. And they focus, in this part of the treatment, they focus on what was the thought and how did that contribute to the depressed feeling, okay? And these are the kind of classic Beck questions that you can ask one way or another with adults or kids. Is there any other way to look at it? What's the evidence for it or against it? And one that kind of throws people for a loop, David Brent likes to use this in working with adolescents because it kind of like gives them a jolt. Like, what are the pros and cons of having that thought? That's not usually the way we think about our thoughts, is having pros and cons. But this gets people to kind of sit back and think about the fact that they could think about things in a different way, possibly in a less depressed way. And then what's the worst thing that could happen if it were true? So these are just some of the ways of questioning a depressive thought. For example, a kid comes in and says, "Nobody likes me. Nobody in my class likes me." You start talking with them about, well, how many kids are in your class? Well, there's like, I don't know how many kids there are in a typical class here locally. I mean, in our area of North Carolina, it's usually about 25 or 30. So, although I went to parochial school in Philadelphia and there were 80, so it's different. But how many kids are in your class? So there's 25 kids in the class. How many of them really don't like you? Well, maybe you end up, by having this conversation, you end up realizing 2 or 3 people don't like them. and they've overgeneralized. Now, what are the barriers to this with adolescents? Well, one of them is they can't identify a thought. They just say they have the feeling. And so what I typically do with that is I ask them, well, if there was a thought, what would it be? Or can you put it into a thought and have them put it down on paper, and then you have something to deal with. The most typical one with teenagers is that they think their thoughts are reality. Remember, they just hit the stage of development where they're learning to do abstract thinking, so they're quite enamored of their thoughts, and it's hard to get them to take any distance from it. And the third is related to that, is that if you find that there's a need for distance from the thought, it's probably better to talk about somebody else rather than the adolescent himself. You could take an example from another person. So these are three of the main strategies in CBT for depression. I chose them because I think there's an emerging consensus that these are probably the big three, and also because there are now computerized CBT programs for adolescent depression that use these three strategies. So there's the Mood Helper program that Greg Clark developed in the state of Washington, in the state of Oregon. There's the Sparks program in Australia. These are computerized programs that may facilitate dissemination and are based on these three strategies. If you're doing a course of treatment, of course, you have resources from other strategies that may prove helpful in any given case, such as relaxation, emotion regulation, including some of the skills from dialectical behavior therapy, working with the family, or practice helping parents adjust their expectations. One of the typical findings in parents of depressed kids is that the expectations of the parents are high, and they tend not to give as much positive reinforcement as other parents. So that's something that can be addressed. Okay, so that's my thoughts about strategies for depression. Now, to go to substance use, this is also one of the most common disorders of adolescence. So I think if you take anxiety disorders, behavior, oppositional and conduct disorder, depression, and substance abuse, they seem to be the big four in terms of prevalence. So CBT has been applied to adolescent substance abuse, and it's one of the well-established treatments. It can be done, as is the case with depression, this can be done individually or in a group. I'm a little hesitant to do it in a group with substance abusers. You can get a lot of war stories and reinforcement of how wild and crazy they were last night. So I tend to do this, we tend to do this in individual sessions in our setting. If you take the CBT model and apply it to substance abuse, the situation is very often peer interactions, peer pressure, or conversely, feeling socially isolated. So some of the kids that we work with who are involved in substance abuse are involved with peers, but it's like they're involved with heavily substance abusing peers because they feel alienated from everybody else. And so that's a very important situation, and you'll see how it affects the strategies. The feelings are craving for substances or feeling lonely or having changes in mood states. The thoughts have to do with giving myself permission to use and expecting that good things are going to happen when I use. The behavior is the use. The short-term consequence is pleasure and social reinforcement. But the long-term consequences, of course, are possible addiction and loss of activities and friends and getting involved in dangerous situations. So you can apply the same kind of functional analysis to substance abuse. What's the trigger? What thoughts and feelings was I having? What did I do? What good things happened and what bad things happened as a result of that? And this is part of the beginning of treatment. However, there's a big difference between depression and substance abuse, which is I don't know anybody that wants to be depressed. But I know a lot of people who want to use substances and really get a lot of pleasure out of them, and therefore it's a struggle to give them up. Therefore, motivation for treatment is a huge issue. And getting better means giving up a major source of reward. In fact, one of my graduate students did a longitudinal study where she followed kids who were in treatment for substance abuse, and as they got better on the substance abuse, their perceived quality of life went down, and then it went up. So it went down while they were getting off the drugs. They really felt a loss, and it was about 3 months later that it picked up, so there was a lag there. So motivational interviewing is often paired with CBT for substance abuse. In fact, I don't know that it would be possible to do CBT without motivational interviewing. So a typical treatment for adolescent substance abuse is a combination of 2 sessions of motivational interviewing plus several sessions of CBT. I'm going to talk about the things on the left-hand column, motivational interviewing, and 3 strategies to deal with substance abuse. These, on the right-hand column, you can see our friend problem solving is there again, as always. These are things that may be useful for substance abusers as well, but the ones on the left are more specific to substance abuse. So motivation enhancement is based on motivational interviewing, which is an art in itself. I wouldn't claim to be a skilled motivational interviewer, but it's a non-confrontational way of addressing substance abuse that's quite different from the traditional 12-step model of confronting and challenging the substance abuser. Okay? What it has to do with is listening to them, getting information from them about how this has affected their lives, and then giving them feedback about that, and getting some goals set based on their ambivalent feelings about substance use. So in working with adolescents, what we do is we start in the assessment by reviewing with them their use of alcohol, marijuana, and other drugs, and we ask about any positive consequences and any negative consequences, and then explore with them possible reasons for quitting. Now, one of the disadvantages of working with adolescent substance abusers is that compared to adults, they haven't really suffered as much in terms of negative consequences. They haven't lost marriages, they haven't lost jobs. So it's a little harder, but they have had some negative consequences. And we ask them about what are possible reasons for quitting. What reasons might you want to, what are some reasons you might want to quit? And these are some examples. You know, they might want to get along better with their parents, do better in school, show somebody that they can do it. Or if it's a case of, in case of alcohol, I want to show that I can drink socially and I won't have problems with it. So you complete the same kind of functional analysis that we talked about before, looking at the triggers for using, the thoughts and emotions linked to substance use, the behavior while using, and the short and long-term consequences. So there's the chart again. This is taken from a manual for MET CBT 12-session version. Now, a couple of treatment strategies for CBT treatment strategies for substance abusers. The first one is refusal skills. I don't know if any of you remember President Reagan. It was in the 80s. I remember him well, but you know. So his wife, you know, usually the first lady in the U.S. has some advocacy that they take part in, and hers was reducing adolescent substance abuse. And so her slogan was, just say no. And, you know, people made fun of her, and isn't this a dumb thing to say? And they're like, well, it's actually not that dumb. I mean, basically you have to say no if you're going to not use, and you're hanging around with people that use. So we work with the kids on how to do this, and it's a kind of assertiveness training specifically to substance abuse. We work with them on their nonverbal skills, like being firm and speaking in a clear voice, making eye contact, and realizing that they're not going to hurt anybody by refusing to use. And then the verbal skills are to say no first and suggest an alternative. If pressed, ask the person to no longer offer you substances. Most of the kids I work with tell me, I don't know if this is true, they tell me that if they do this, their friends will not press them to use. I don't know, maybe Maybe, but that's what they say. So they feel like this is doable. So here are some examples. See what you think of these examples. Are these good examples or bad examples of refusal skills? I don't really want to, but if you do, okay, I'll use. Not so good. I can't tonight because my parents are home. Maybe tomorrow. Right? No, I'm getting drug tested tomorrow. See, these are kind of like time limited, these two. So they don't really make a firm commitment. Whereas these two, no, I don't do that anymore, or I have quit that. Let's go to the court and play basketball. Those are like your ideal ones, okay? Okay, so that's the first strategy. The second strategy is related to it, and that is enhancing social support. You can see the difference here between treating depression and treating substance use. There's much more emphasis in the substance use treatment on the social situation, because for teenagers, that is almost always involved in their use. So you want them to be firm against pressure, but also to make sure they have enough social support, because they're going to be giving up some social support when they give up substance use. So quitting substances can be stressful. You'll need social support. So we ask them, who might be able to support you as you work toward the goal of abstinence or reduced use? And this is a little form that we give them in sessions to kind of visualize their social support system. So it's hard to read the instructions, but it says put your name in the center space, this one here, and then fill in the names of those who already do or could support you in your goal. Put the people who could be of greatest support close to your space and fill in as many spaces as you can. And then we work with them to ask for the kind of support they will need. Is it information? Is it emotional support or encouragement? Is it help with problem solving? In some cases, they may need urgent help like money or housing. And we ask them to practice offering support to other people so they see what it's like from the other side. Now the third, the last strategy I'm going to mention is the cognitive strategy. The cognitive work for substance abuse is a little more complicated and variable than it is for depression. For depression, you're usually working on negative, self-critical thoughts about the self, other people, or the future. That's Beck's, triad. With substance use, you're working on all different kinds of thoughts that are related to their cravings and their tendency to relapse. So it could be related to triggers, thoughts about drugs, or excuses to use. And you work with the kids to normalize their expectancy that they're going to have cravings, but that cravings are not the same as actions, and that cravings are time limited, like waves. If you've worked with suicidal people, you use this too, right? Suicidal impulses come in waves, and if you can ride the wave and get over it, you'll be better. It's the same kind of thing with substance use. You help them to identify risky thoughts, thoughts that facilitate using substances. So happy memories of use, like a guy that I've been working with recently talks about good times he has had with a friend of his when they do cocaine. And it's like he can't figure out a way to be with this girl without using cocaine. A thought about overconfidence about control, I can handle it, or hopelessness about control. There's no use even trying because I am an addict, I am just an addict, and there's nothing anybody can do about it. The perceived need for a substance. We've all felt this at the end of a hard day of work. I have to have a drink, okay? Most of the time that doesn't cause a problem, but if you have a substance abuse disorder, it does cause a problem. And then expectancies that this will help me relax or escape. okay? Or just the kind of like, I've been in treatment for a long time, I'm sick of it, I'm just going to use, okay? Those are all the kinds of examples of all the kinds of thoughts that substance abusing kids will come up with. So we work with them then on developing coping behaviors for when they are in a circumstance that's a high risk for use. And this is different from the anxiety disorders. You know, in the anxiety disorders, treatment of anxiety disorders, you don't want people to avoid the thing that they're anxious about. You want them to expose themselves to it. However, in the treatment of substance use, if there are certain places or people or circumstances that are associated with use, then you do want them to avoid it. So the 12-step people call this, you got to change playgrounds and playmates, okay? And that's what this means. If you're always, we worked with one kid who always used drugs when he went to the basketball court, which threw me for a loop because I usually send people to the basketball court, you know, to get over drug abuse. But that's where they were using, so he had to avoid that particular basketball court. You work with them to delay responding to the urge, just as you would with suicidal people, delay responding to the urge to harm yourself. Distract attention, seek social support. Go back to that social support network that you worked on earlier and identify people that you can contact when you feel like you need to have some help avoiding substance use. Challenge the thoughts. This is like CBT for depression. Challenge the permission-giving thoughts, like, it won't hurt to do this, or I can handle it. And then go back to the reasons for quitting. So I talked about motivational interviewing as happening before CBT, but it also happens during CBT. So you do it at the beginning, but then you come back to it repeatedly as the motivation wanes during the course of CBT. And then practicing long-term consequential thinking. So substance abusers are a little bit like oppositional kids in that they tend to think short-term. And helping them to practice thinking about long-term consequences is key to the CBT for this particular disorder. Okay. Now, I said that I had thought about these things in terms of dissemination. So within the United States, we have tried various models of dissemination, and some of them work better than others. One of the ones we do, of course, is the training the trainers model, where we will have workshops, train people in CBT, and then we'll supervise them as they supervise local providers. That's one method. Another is to triage the demand. So this is more relevant for depression, actually, but many people benefit from just a couple of sessions of supportive therapy for depression, and they seem to recover from that without needing to go into a full course of CBT or medication. The other one that I mentioned earlier is electronic or computerized CBT. Seems to be quite helpful for dissemination. Now, in the area of depression, it's actually been done as a standalone treatment. So the Mood Helper program is a combination of behavioral activation, problem solving, and cognitive restructuring that kids can do online. And it seems to have a fairly good effect. It's not quite as powerful as face-to-face treatment, but it does have a positive effect. In the field of substance abuse, I'm not aware of anybody using electronic or computerized CBT as a standalone treatment, but it is used as a supplement to regular treatment. So the people at Yale have developed a program that's called CBT for CBT. I can't figure out what that means, but it's like 6 skills or strategies that the patients can use on their own as they're going through the course of treatment. So that may be something, I know some people this afternoon are going to be talking about telepsychology and telehealth, and that would be an example of that. And then finally, an obvious challenge is cultural tailoring. So I've only worked in the United States, and actually I've only worked in the eastern United States. I don't even know how I would do out west, but you know, you would have to adapt these to your local cultural situation. It seems that the research on cognitive behavior therapy and other therapies with minority kids in the United States suggests to me that the treatments work. The challenge is maintaining the alliance and keeping the kids in the treatment. So they do better if they have a therapist who's more similar to them, and they tend to stay in treatment more if they have a therapist who's more similar to them. The actual treatment seems to work okay if you can handle that challenge. Okay. So those are my conclusions. A general model of CBT can be applied to various problems, including depression, substance use. Specific strategies can be embedded in that model. Providers can be trained in it, but there are dissemination challenges. So I want to thank the organizers here, the Duke Global Health Institute for supporting my travel. National Institute on Alcohol Abuse and Alcoholism is funding our current study. And these are my colleagues at Duke and the University of Connecticut and the people who worked on the Treatment for Adolescents with Depression study. Thank you very much.